CME credit. Uh, Sovah Health is accredited by the Southern States CME Collaborative to provide continuing medical education for physicians. In addition, we are pleased to provide 1.5 hours of Virginia Nurses Association accredited CE credit for the program also. The program is developed to promote several desirable physician attributes, which include our providing patient-centered care, utilizing evidence-based medicine practice, and to also utilize informatics and some of the data sets that are utilized, you'll hear about this evening, that help us provide better and safe care. Dr. Mooring, Dr. Spillman, Ms. Boardwine, myself, and members of the Sovah Health CME committee have nothing to disclose as far as commercial relationships, and there is no commercial support for the program this evening. It is supported, as are all of our online programs, by an educational grant from the Ralph Landis Medical Education Fund, which resides at the Danville Community College Educational Foundation. Dr. Landis created this fund upon the time of his retirement, which provides support for CME programs for all forms of healthcare providers and healthcare professionals throughout the area in or around Danville and Martinsville, Virginia. You will receive this evening or tomorrow by email a CME evaluation form from after this program. You will be asked in that email or in that form to once again enter your name and your email address. This is important for you to be aware that you need to give us your real full name, because that's what will be on your CME certificate that will be emailed to you once the evaluation form is received. Please don't use any nicknames or short names. Please give us the full name so we can send you an appropriate certificate. If someone is watching, listening to the program this evening with you, with your logo, as it were, please let us know that so that we can give that person credit for the program also. In addition, an eval form is not necessary to receive your CME credit if you're a physician, but it is required for nurses, nurse practitioners to receive CE credit. In addition, we are providing a new option for doing the evaluation. A QR code will be put into the team's chat box towards the end of this program. If you prefer, you can access the eval form through the QR code, and or you'll still receive it by email once the program's over. The CME certificates, as I said, will be emailed to you once the eval is returned. If you choose not to do an evaluation form, we still will send you a CME certificate for your participation. For the medical residents who are on the call tonight, you do not need to keep up with your CME certificates. We report your participation to your respective program coordinator, Darrell Johnson, or Lori, and so they will be aware that you attended and keep up with that sort of tracking. If you have any question about the CME certificates, the eval forms, or follow-up questions about the program, please don't hesitate to email myself or Mary Kent, our CME coordinator, and or Vandora Holt, who is our nursing educational director for our market, both campuses. And that being said, I like always to especially thank them for their help in our producing the program this evening and allowing all of us to have these fantastic CME talks that we have throughout the year. We urge, and I know all three speakers hope, you will provide questions for them, interactions, questions or comments. It is totally urged, and it makes the program so much more, if you will, vibrant, relative, and just entertaining. So if you want to ask a question, you can do that either through the chat. Mary will be monitoring that through the evening, or do the little raised hand thing. In addition, I know all three speakers are going to ask you if you have questions. Once you ask your question, or when you ask your question, please identify yourself and the type of healthcare professional you are. It makes it a little more, if you will, satisfying for the conversation. Once you've asked the question or made your comment, please mute your phone for the speaker's response to avoid feedback. You are welcome to have as many questions and comments as you would like to make. And again, we urge you to please, please, please do that. I want to highlight for you very briefly some upcoming programs. And we really are having a lot of programs during this first quarter of this year. Each year in February, it being Heart Month, we usually have a series of cardiology centric talks, and that is what we're doing this year. On February 6th, there will be an update on the current management of atrial fibrillation by Dr. Passini. He's the director of the electrophysiology program at Duke. And the second talk will be managing deep vein thrombosis or thrombophlebitis and or pulmonary embolus, as well as perioperative chronic anticoagulation by Dr. Kapoor, who's one of the hematologists at Duke. The week after that, on February 13th, Dr. Jennifer Reimer, who participated in developing the New American Heart Association guidelines for cardiovascular management of perioperative patients, will be presenting those new guidelines to us. This with situations where a patient coming in for a non-cardiac purpose, perhaps an elective hernia repair or other surgery, and their own cardiovascular drugs, or have major cardiovascular problems, how should those drugs and that cardiology problem be safely and appropriately managed as they enter hospital, have anesthesia exposure, and then are going home. Then March 6th, because we are one week off on every Thursday in February, the last cardiology lecture will be on March 6th, which is on heart failure, which will be Dr. Stephen Green, who we've had do this before, review the current guidelines for treatment of heart failure, followed by something that's just emerging at many medical centers, including Duke, which is remote monitoring of heart failure, the implantation of certain devices so that patients' volume status and other things can be monitored remotely once they've gone home. And Dr. Vadim leads that section within Duke Cardiology. On February 20th, we are having what I think is a special program. Dr. Aaron Gettler, a part of the Division of Infectious Disease and a member of the DASON group, who you've heard from last time we gathered when Dr. Anderson talked. Dr. Gettler is going to talk about UTI antibiotic stewardship, both in the cultures as well as the appropriate use of antibiotics for patients. And then finally, on Thursday, the last Thursday in the month, Dr. Kimberly Beavers, who's a member of our GI medical staff here at Sovah Health, will be talking about the epidemiology, risk factors, and I think most importantly, the current optimal screening strategies for colon cancer. As I'm sure most of you know, the incidence of colon cancer is increasing in this country, and not only that, it's increasing and occurring at younger ages than have previously been the case. So Dr. Beavers will be talking about that, as well as what is the best way to screen your patients for colon cancer. Well, this evening we're delighted to have what is the second in our infectious disease series, having had one 2 weeks ago. And this evening we have, as I know you know, two lectures for you this evening. The first is with Dr. Rebecca Mooring, who is a member of the Duke Infectious Disease Group as well as the DASON program. Dr. Mooring has, I think, a very remarkable background. She did her undergraduate work at the University of North Carolina at Chapel Hill with a double, almost triple major in biology and music performance. Her instrument of excellence is the flute. And if you're familiar with UNC Chapel Hill, to have a dual degree from Venable Hall, where chemistry is taught, and from Hill Hall, where music's taught, is not a common thing. In addition, she had her minor in chemistry. She was a member of Phi Beta Kappa as an undergraduate. She then did her medical school training at the Virginia Commonwealth University in Richmond, where she was selected for AOA, or Alpha Omega Alpha, which is the Honor Society for Excellence in medical schools. She did her internal medicine residency and internships at Northwestern in Chicago, and then came to Duke for infectious disease fellowships, returning to the University of North Carolina in Chapel Hill for her master's in public health there. She has authored many articles and books. She has 8 book chapters to her record, numerous articles, and she's also, which I think is a real nice accolade, she's one of the contributors to Up to Date in the infectious disease section. So it's just a delight to have her talk with you about outpatient antimicrobial stewardship and actually what might be said transition of care, appropriate management of focusing on antibiotics. So Dr. Mari, if you'll bring your slides up, mine will come down. And that being said, we thank you for doing this.
Thanks for the introduction, and sorry for the technical hiccup for a second there, Mary. We were
nobody has to know.
So hopefully y'all can see my screen.
There you go.
Yeah, we'll just get into presenter mode. Okay, well, thanks. All right. Thanks for the introduction, and thanks for having me back. Really excited to be here to talk to you about, I think, a topic that is pretty hot right now in the field of antibiotic stewardship. A lot of people are trying to figure out how to do this well. So I will try to take you through a couple of the strategies that have worked in some settings, and hopefully this will trigger you to think about how things work in Danville and how maybe y'all can work as a team to try and make some improvements here. So first, I'll just review what we know about the opportunities for improvement in stewardship, and also like how we capture antibiotic use data at the transition of care, especially upon hospital discharge. And then I'll go through several examples of how folks have kind of tackled this problem and what strategies they have used for the transitions of care piece of stewardship. And then very briefly at the end, I'll review some strategies used for emergency department discharges, and then also discharges to skilled nursing facilities. Just to give you a little bit more background, I know Dr. Moore gave a lot. Just wanted to give you an idea of what my day job is like. So you can see me on this slide with what I consider to be my team. This is my stewardship team at Duke. It is multidisciplinary. The 3 folks in the circles on the left are my pharmacist colleagues who are ID pharmacists. And then I have 2 pediatric ID physicians on this slide as well, Dr. Smith, Dr. Murthy. And then the 2 guys at the bottom are my other adult ID colleagues that give some of their time to work with me on projects, as well as some of the daily work that we do within Duke Hospital to support teams that are making decisions about antibiotics. So part of my day job is actually going around to the hospital and chatting through cases with people to see what opportunities we have that right then, right there for that patient to try and improve their antibiotic decision making. And a lot of my time is just cheering people on because they're doing a really good and thoughtful job and just reflecting back on kind of how they're supporting their clinical reasoning and what they're doing. So I really enjoy this work. It's what gets me up in the morning, and a lot of the reason of that are the people on this slide. The other thing that I'm involved with and that Danville is also a member of is our outreach network. I support this in some ways with some of the content, educational content, and also some of our data infrastructure decisions. But this is basically a collaborative network of more than 30 hospitals in the Southeast area. And we do things just together in terms of sharing our data with each other and sharing our experiences in stewardship. So Libby Dodds Ashley is the leader of the network, and I think she's given some talks for y'all before, but she leads this network where we have on-site visits with member hospitals. We do education. We provide educational content like newsletters and CE programs as well. And then we also share the data. So I'm going to give you a little bit of an example of some data that we've used within this network to try and help with antibiotic stewardship. So in this hospital network, one of the things that we do is just provide rates of antibiotic use, basically, that kind of data back. And the one metric that we often look at is this thing in the middle. I know it has a lot of abbreviations, but it's basically for every patient that gets an antibiotic, and in this case, it's IV vancomycin. For every vancomycin patient, about how many days on average are they getting an antibiotic? And you can see that for this hospital, it was around 2.8 days of vancomycin per vancomycin admission. And if you compare that to other hospitals within the network, it's actually a little bit lower. But we see that the overall rate is higher than other hospitals, and the percent of patients getting vanc is a little bit higher than other hospitals. So this pattern really suggests that this particular hospital that we're looking at, Hospital H, is giving vancomycin frequently to a larger portion of patients than in other hospitals, but giving it to them for a short period of time. So we use these metrics to kind of understand the way the antibiotic is being used and then come up with strategies. What's also nice about this kind of average duration metric is that we can track it over time and see the effects of different strategies that we're using. So for example, at this hospital, they started an antibiotic timeout during this time period, and then they started using MRSA nasal PCR to help with vancomycin de-escalation. And you can see that average duration kind of coming down for this hospital. And then finally, we can compare it to other hospitals. So each bar on this graph represents an individual hospital. And you can look at the mean and then compare that to each individual hospital to see like where you are in terms of your average duration. So it's one thing that we've been like paying attention to for many years and using it to develop strategy. But the problem is that this is only telling us what patients get like while they're in the four walls of the hospital. It really doesn't tell us what happens in terms of their total duration of antibiotics that they get. So we had this question and we wanted to, see if we could actually capture that data. And April Dyer, one of my colleagues in Daesan, really led this pilot study of trying to capture that data from the electronic health record and try to understand, how much of that prescribing happened on discharge, and are there opportunities there? How can we capture that data and how can we learn from it? So this study was in 2 community hospitals and our academic hospital at Duke. We looked at all inpatient admissions and tried to just link up what we saw in their electronic medical admission records in the hospital, and then link that to information on electronic prescriptions that happened as they were leaving the hospital. We also did a validation just to make sure that we were actually capturing the data completely. So we took a 300 patient cohort, looked at their charts, and saw if there were any holes in the data. And what we found did surprise us a little bit when we just looked at some of this data. The main thing is just that those post-discharge antibiotic days actually made up 38% of the antibiotic days attributed to the inpatient stay. So we always think that patients are just getting hammered with antibiotics in the hospital, but that post-discharge time period actually makes up at least a third, closer to 40% of those antibiotic days. So those decisions that we make at discharge are a pretty sizable chunk. The other thing that we saw is when we lined the data up and looked at durations, like with the day that they were discharged, we saw these spikes emerging. And they were emerging at like 7 days, 10 days, 14 days, 30 days. So to us, this indicated, hey, wait a minute, like we shouldn't be restarting 7 days if the patient has already been in the hospital and gotten antibiotics for a few days. So why are we seeing these patterns? It should be smoother, more like what's at the top. And so this started us asking questions like, okay, well, are people just like restarting their whole antibiotic duration at the time of discharge? Or maybe like they're just following defaults on their order entry panels that always are just like set to 7, 10 days. And so this started us asking questions. when we did the validation step, we actually saw that there were several holes in that electronic prescription data. The main one being the patients that were discharged on IV antibiotics, either through a home health team with outpatient therapy or discharged to a skilled nursing facility. We really didn't have that information in those electronic prescriptions. And then patients on dialysis that were also getting antibiotics. The other thing we found is that at that point, and this data is a little bit old, not all the clinicians that were working at the hospital where we did the validation had totally embraced the concept of electronic scripts. And so they were still walking around with paper scripts in their pocket and writing those as people were leaving the hospital. So we saw some of that. And then we did see a little bit of messiness in this electronic prescription data where we had to kind of like look at the sig and the quantity and try to calculate like how many days that was. And in some cases, you couldn't really interpret it or come up with an estimate. Some other findings, among all admissions to the hospital, about 17% of those admissions resulted in an electronic script for an antibiotic. And then we saw some scenarios where there were just really, really long durations. And we saw that the hospital doctors were actually writing for up to a year, especially for prophylaxis indications. And then finally, about a quarter of these electronic scripts on discharge were for fluoroquinolones, which are a higher risk antibiotic agent. So after we did this, another group from the VA system actually kind of took the same idea and looked at just the giant database that the Veterans Health System has. And so this study was, 1.6 million admissions, large number of hospitals, veterans hospitals. And learning from our validation study, they were like, well, let's just look at oral antibiotics because we know there's a lot of holes in this data. And kind of excluded some of those areas where we know we wouldn't have like complete data capture. What's reassuring is they found very similar findings to ours in the Veterans Hospital. 39% of the days occurred post-discharge, and even more quinolone use was seen in our veteran population from this study. They also saw that, hospitals that tended to have higher antibiotic use rates for their inpatient side also tended to have higher post-discharge antibiotic prescribing rates. And that's what that graph shows there at the bottom left. So the other study that I wanted to highlight that kind of shows where some opportunities are comes from the Michigan Hospital Medicine Safety Consortium. And I'm going to touch on this a little bit when we talk about strategies. But what's great about HMS is that they have resources for a lot of quality improvement and audits in terms of their chart reviews. So they were actually able to grab a cohort of 2,000 patients from Michigan and 46 hospitals. And these were all patients that had a diagnosis of pneumonia or UTI. So they could actually look at some syndrome-based metrics to look for opportunities. And these were the findings. Nearly half of these discharges, these 2,000 admissions, had some type of antibiotic overuse at discharge. For the pneumonia patients, most of that was due to just excess durations of therapy in excess of what's recommended from standard guidelines. In UTI admissions, it was more about patients who didn't actually have UTIs. They had asymptomatic bacteria. And so those overuse for UTI really was more about getting the diagnosis right rather than prescribing the right number of days of therapy. So in summary, that observational data that I just went through, really we see that these post-discharge antibiotics make up a huge chunk, 38 to 40% of antibiotic days of therapy attributed to just the hospital stay. And we see a couple areas that we might improve. One is just like using shorter durations and evidence-based durations. Two, avoiding that diagnostic error, especially associated with UTI. And then perhaps there may be some opportunity for us to better choose a narrower, safer antibiotic as compared to things like quinolones. The other thing that I think this data really showed was that we have some issues with counting antibiotic days. And it may not be like an individual person doesn't count up the days in the hospital and then add that to a total duration. It may be more of a system problem with like defaults in our ordering systems. And so being able to making sure that we're counting the days of intended treatment course and not just restarting the clock at discharge is one of the things that we observed. Now, that being said, discharge is just a really tenuous time for patients, that post-discharge period. We know that, a large chunk, a fifth of patients will have some type of adverse event within 3 weeks of discharge. And if you look at Medicare populations, you see that 20% metric again. And that patients like leaving after a surgical problem, they're coming back with a medical problem when they have a post-discharge event. We also know that like there's a bunch of logistics that go into discharge, just making sure the medication list is right and accurate, making sure the patients can go pick up their medicines from pharmacy and afford and access those. If they're discharged at, 8 p.m. and your local pharmacy closes at 9 p.m., getting there before the pharmacy closes, they may have to wait till the next day, for example. And then this has been a focus of many, federal programs. These are just a couple of links from the HRQ, but also really a big focus for CMS. And there used to be like rules for financial penalties like earlier in the prior decade. And I think like the biggest problem with transitions of care is that, it's like who does what. So I think the Spider-Man meme does a good job of capturing the problem. It's like, once they're out of the door, the hospital team is like, okay, we did our job. Now the outpatient folks need to take over, or their SNF folks need to take over. And it's like, once that patient leaves, like who's really looking out for them? And did, Spider-Man number 1 actually talk and communicate with Spider-Man number 2 that's taking over their care to make sure that they understood the plan and they're ready to step in when the patient needs them in that really tenuous post-discharge period. So what can we do for stewardship at this time period that's so difficult and rushed and full of lots of logistical hurdles? So I think there's a couple of things and a couple of like key principles that hopefully I will show you as I go through a few of these other studies. One, I think it's important to just try and measure some of our post-discharge antibiotic use so that we can recognize those opportunities for improvement. And, maybe getting the IV and the SNF and the dialysis data is more challenging, but even if we just have those oral prescriptions, like in that VA study, that's still going to give us a lot of area where we can work and improve. And you can either look at that like globally, like the VA study and the study we did, or you can do it more syndrome focused to be able to feed that data back and learn from it. Education is also a big component with any improvement project, but I think especially with transitions of care, understanding what the standard duration is, and then reassessing that and helping team members assess that duration. Integrating that into things you're already doing is also another big thing. I bet every person that lives in or that works in a hospital knows that there's a transitions team and a case management team that is doing huddles every single day to try and make a discharge plan for a patient. So if there's any way that we can get some of this discussion about antibiotics into those existing processes, we certainly should do so. And then I think the other team member that really can help, especially with counting issues that we have with days, is pharmacists. So pharmacists can absolutely support both on the inpatient side before patients leave, but also on the outpatient side. So I'll give you a couple of strategy examples from that. The other suggestions I have are kind of just like some best practice processes that I think are good as physicians and prescribers for us to remember. And these are some of the things that I use when I'm teaching fellows or, rounding in the hospital and saying, okay, you got that stop date in? Okay, here, let's make sure that's right. And what was day 0? Let's make sure count out 7 days and get that stop date in the order. So when you hand off tomorrow, the next guy doesn't have to think through that. One of my pet peeves is when I see in notes, this is antibiotic day, 3 of 5 or 3 of 7, which is something that is notoriously not updated daily. So I encourage people to write those stop dates into their notes. This helps with, communicating to our pharmacists, to the person you're handing off to. And in electronic records now, which really includes a lot of copy forward, writing the date is way better than writing it as X of Y. Reviewing orders daily, I think, is also really important, and not just relying on your automated systems, or say like, oh, well, the pharmacist will pick this up if I screw it up. Don't rely on other people. Take it upon yourself to make sure that your orders are right every single day. And then I think, the other thing is just like, don't assume everybody knows like why you wrote that order or what's it for. So talking about that during your huddles, indicating that on your order, all of those things help with communication. And then these last do's and don'ts, I think really speak to some of the things that we picked up in some of that observational data, is counting the inpatient days as part of the total course and not restarting the clock at the time of discharge. And then doing these timeouts or huddles to constantly reassess and make sure that the intended duration for antibiotics is communicated. Don't just like go by what somebody wrote before. Make sure you understand the rationale why. All right. So some of the ideas that we had, in looking at that observational data, other investigators have as well, and we made this framework that should help kind of look at the 3 different tiers where we might intervene to improve our antibiotic use at discharge. This tier 1 is probably things that your hospital antibiotic stewardship program is already doing. There should be some amount of human resources devoted to antibiotic stewardship. There's probably a policy. There are probably at least a few institutional guidelines, and then education is always a component of improvement projects. Tier 2 are also things that your inpatient stewardship team might already be doing. And tier 3 is really where we can add additional strategies on top of some of this infrastructure to try and make some improvements. So next, I'm going to go through a couple of strategy examples from the literature from 3 different groups. But again, all 3 of these have some of those components you saw in that middle tier, institution-based guidelines and education being the main ones. So this example comes from Denver Health. And this is a great example of how this team really engaged pharmacists to assist prescribers in updating their decision-making based on standard duration guidelines. So what was really nice, this is a little bit of an older study, but this was really one of the first examples of an institutional guideline that not just like gave you like, oh, this is what you should use empirically when somebody shows up with pneumonia, but actually gave instructions for, okay, here are the good antibiotics to switch you for oral, and this is how long you need to give them. And so they created these institutional guidelines, distributed them in the various ways that they had, and then used these guidelines to then have their outpatient pharmacist who was receiving these antibiotic orders do a quick audit, look at the indication, look at the number of days that were prescribed upon discharge. And then if it was consistent with the guideline, they just went ahead and filled it. If it wasn't, then they kicked the case over to the stewardship pharmacist that worked on the inpatient side and, had ready access to the hospitalists and the folks surrounding in the hospital. And then they could talk to the prescriber and determine whether that order needed to be updated. This is the example of the guideline, and this again is dated, so I don't want you to get into the weeds of what exactly is suggested here. But basically, the structure is that they had the syndrome kind of on the left. They had the inpatient empiric therapy, and then what they suggest for the oral transition, and then the total suggested duration, kind of in that last column. And so instituting this strategy and doing the audits actually showed that they successfully reduced the number of quinolone scripts that they had. Successfully, they had a decline in the total number of days duration, although it was not statistically significant. It was 1 day difference. And then they had a decline in the duration prescribed at discharge. And this is where that little piece of the duration was impacted most. And again, a difference of 1 day. So that can work, right? Just working together, having an additional audit to be like, okay, are you sure that's the duration you want? Are you sure that's the agent that you want? This next example comes from the HMS consortium that I mentioned, that for those 46 hospitals that were looking at their syndrome-based metrics for pneumonia and UTI. I think what is really unique about this project, again, is that they have a team of chart auditors to be able to collect the data. And the way that they did this, it was actually supported by a payer. So Blue Cross Blue Shield of Michigan supported this collaborative with providing support for chart abstraction to get the data. And so they basically used their chart extractors to look at how often folks with community-acquired pneumonia were getting a 5-day duration standard. And then they benchmarked that with the other hospitals in the collaborative and tracked their adverse events. Then they collaborated 3 times a year. They had a big meeting where they talked about strategy. They discussed the key literature. They looked at their data together and distributed their guidelines, especially around duration. And then the third thing was the kicker. Obviously, they provided some money behind it. So they provided a financial incentive for each one of the hospitals to meet their target or their goal. And so these were the targets. They were like, okay, in 2018, you're, at least 20% of those eligible for a 5-day therapy duration should get it. In 2019, they increased it a little bit. In 2020, up to greater than 50%. And so of the clinicians out there, they're like, oh, wait, but who's eligible for 5 days? So they made a definition for uncomplicated community-acquired pneumonia based on the data that they could get from their chart abstractions. And this gives you a little bit of an idea of some of the exclusions, and there were a fair number of exclusions. And again, this was a hospital medicine group, so they came up with these exclusions collaboratively among the group of hospital medicine doctors. And this is an example of the hospital level summary that they provided back, just like the proportions that were CAP versus possible pneumonia. That's the little yellow piece versus what they're calling a healthcare associated. The expected duration, the 5 days would be that blue piece. And then the number meeting the metric for 5 days, they had a 60-40 split at this hospital. So by doing this collaborative, by doing a lot of chart abstraction, feeding that data back, collaborating with each other to try and meet these goals and providing a financial incentive, they did see a higher adherence rate with the 5-day standard, 20% up to 43%. And so that's an improvement about 10% each quarter. And then when they looked at their adverse outcomes, they actually saw that they improved over time. And most of these were just like patient-reported adverse outcomes. So these are things that you may not pick up unless you're actually calling your patient in 30 days and be like, okay, so how did you do on your antibiotics? And so after they got further on with shorter days of antibiotics, there were less patients that reported a problem with their antibiotics. And most of this was diarrhea, okay? All right, example number 3 is from Henry Ford up in Detroit. This is a very much a strategy led by pharmacists. And it was very much also syndrome focused. So you can see the syndromes that they chose were things that are more straightforward rather than some of these more complex infections. In their health system, they have like one health system. They developed a bunch of implementation tools, and all of these are available online should you be interested in seeing them on the Henry Ford website. I'm going to bring a couple into a couple slides. But basically, they give you syndrome-focused guidelines, what they use at their hospital, how to have discussions about the process of transitions on antibiotics, an example workflow for pharmacists, and then just educational handouts. So a lot of these tools are freely available to anyone that wants to go grab them from the internet. And this is an example of their institutional guideline. Looks very much similar to what I showed you from Denver, right? Where they have the syndrome here, the suggestion for their discharge or transition for discharge agents and doses, and then the duration there on the right side. And so this was like a reference card that they could use to both audit or talk through cases while they were doing team-based rounds. And a lot of these discussions, again, were led by the pharmacists that were on the floor. And so it was both the stewardship pharmacists and the primary, like clinical pharmacists that were working with the medicine and surgery patients that had these diagnoses. And so this is the example for the pharmacist workflow, is just to do a chart review, understand if the patient's going to be discharged, and then try to attend rounds and have an in-person discussion with the team. And especially if the planned duration was longer than was standard, they would talk through that and talk about just why this patient is an exception, and what the rationale for that is. And then they'd actually help the clinician, the prescribers, by updating their orders and actually putting in their discharge order with the planned stop date. So the pharmacist took an active role in not only like prompting the discussion, but actually updating the order with the end date on it as well. And so for this study at Henry Ford, there were several strengths. One, it included, all the health system hospitals, five hospitals in their system, both community and academic sites. And they had a big impact on what they defined as optimized discharge prescriptions. So you can see the overall effect here. It increased by 45% in terms of optimal versus where they started at about a third. And then when you look down here, you can see the areas where they mostly impacted. And guess what? It's those areas that we had identified when we looked at that observational data: the prolonged duration, treatment of ASB again, and then trying to select a more narrow agent. So this is the areas where they were able to improve. And then looking at patient outcomes, again, where they saw the most impact, similar to where they saw in Michigan, it was really on these adverse drug effects. And even in this study in particular, they were able to find a significant reduction in MDRO, so multi-drug resistant organisms, at 90 days as well. The other outcomes, like mortality, readmission, those things weren't as impressively changing. So I think, this study in particular just really highlights how pharmacists can take an active role in discussing antibiotic durations. As I said, I think pharmacists are a little bit better at math than physicians sometimes. That's true for me, at least. And I think it's just a nice chance for there to be a team-based multidisciplinary discussion about like what the plan is, so that, the teammates can help each other. And so sometimes, we write orders, it's not really clear why or the rationale why. And sometimes just voicing that helps validate some of those decisions and kind of come up to that decision as a team. And also we can share information. So like, they may not understand that the clinical response was like delayed, and that's the rationale for the longer duration. So just talking through those rationales also just helps us reinforce our clinical decision making. And then also pharmacists are very good at triggering discussions about, oh, can't we switch this over to PO? And switching earlier to the discharge regimen also gives your patient a chance to adjust to that oral antibiotic, make sure they're not going to have an adverse event before they leave. And then by the time their discharge comes around, that is just a seamless transition from hospital to home. So that is what I had for the hospital-focused strategies. I did want to talk a little bit about the ED and skilled nursing facilities in particular, because that was an area that Michael had said that there'd be interest. And so some of these are really specific that I'll go over. But I think the key principles are similar to what I discussed for the inpatient setting. First is just coming up with a standard guideline that already promotes short antibiotic durations and selection of agents that are really based on your local antibiogram and are appropriately narrow, and avoiding the higher risk antibiotics. Integrating those things into your ordering process as much as possible. And then I think especially important for ED discharges, more similar to the ambulatory space, we really should focus on patient and caregiver education, especially for return criteria, because the things that matter most, the outcome that matters most is trying to avoid people having to come back to the emergency department because they're not well or they didn't understand what they were supposed to do. So that piece is actually very, very important because there's not a nurse to like see them every day, like in the hospital, and do education that way. And then I think the other really tricky thing in the ED is what to do when the patient leaves the ER, but there's still data pending. And I think often, you know, especially for urine cultures or blood cultures that come back positive after the patient has left, a lot of that follow-up ends up being done by the nursing staff or nursing triage, and then like kind of overseen by a physician. So this example comes from our health system at Duke and was led by our pharmacist team. First, just coming up with a treatment guideline, and you can see a screenshot of that here. And then doing both education and data feedback to really enforce the first line, second line options for patients treated empirically for UTI. So there was 2 phases of data feedback. One was just providing department level information on how often, you know, every patient that came to the ED with a UTI diagnosis got a first or second line agent selected. And then part 2 was actually giving individual providers data feedback on how they did over a time period with their patients and selection. What was really interesting about this study is that all 3 of the EDs in our system were starting at different baselines. So if you look at the data, you can see in the academic ED, we were probably about 50% concordant with guidelines to start with. In the other community hospital ED, it was close to that as well. But then, you know, our other community hospital, we're starting more around like 30% adherent. For all 3 of these, we did see improvement, especially after that last piece where providers were getting individualized feedback. Again, we felt like just the education and data feedback on the department level probably wasn't as impactful as getting your own specific data back. At the end, we achieved around 56% guideline concordance, which doesn't seem like hugely an amount that is wonderful. But the truth is, the way that we included patients, it was everybody that had a UTI diagnosis. And in many of those cases, when we did chart review later on, there were reasons that patients weren't getting the first 2 agents: allergies, prior resistant bacteria, you know, prolonged need for antibiotics because they were a complex urology patient. So in those cases, like the standard guidelines didn't necessarily apply. So that was really important learning for us. It's just like, okay, our goal is not 100% adherence with guidelines. We want people to use their clinical judgment when needed. So maybe 60% really should be our goal for all comers to the ED with the UTI. So that's example 1. This example really touches on the need for help with follow-up. So this grew out of a realization that there were patients that are getting called back to the emergency department for positive blood cultures when it just was representing a contaminant. And so we had some patients driving back to Duke for like 2-3 hours to come back to the ER for the doctor to be like, actually, you're good. That's not really a problem for you. This was just a contaminated blood culture. You can leave now. You can imagine the response if you're a patient and you just drove 2 hours to the Duke ED, which is like slam the patients and you know, to be told to go home. So this wasn't good. So because we knew that our nursing staff was helping us with reviewing cultures, we made this pretty simple algorithm that you see on this right side as a decision tree support to try and help with that decision making and gather the information that an ED doctor overseeing these folks and going through cultures really quick could make a call on whether the patient needs to come back to the ED or not. So these are the questions that we asked. And kind of instead of just like calling anybody with a positive culture back, we did a phone call instead and say, okay, how are you doing? This is a nurse from the Duke ED who wanted to see how you were doing because one of your cultures came back positive. They gathered the information on the phone and then had a call with the ED provider. And that actually successfully reduced these callbacks that we were getting, senseless callbacks for coagulase negative staph. And everybody loves that. The patients love it. The ED providers love it when there's less patients in the beds that are over volumed. And so this was a big win for us. And I think, we're interested in developing other decision tree type algorithms for our nurses doing these culture follow-ups for UTI. So that's the next one we're going to work on. All right. I did want to touch just briefly on skilled nursing facilities because I think this is definitely one where it becomes a Spider-Man meme of like, that's your job, this is my job type of thing. And the truth is it's like both sides need to work together. On the inpatient side, we really need to do a better job about trying to communicate what the plan is and what the indication is for the antibiotic. What the end date is, very, very important. If there's any monitoring and what the follow-up plan is. And also, I think this last one gets skipped a lot in our discharge instructions for our SNF. It's like, what should bring the patient back? What are we looking for if this isn't going to work? And so the same type of things that you would do, same type of like anticipatory guidance or return precautions that you would give to somebody being discharged home or being discharged to the ED, you should think about that the same for your SNF. And the reason is that there's not a doctor at the SNF at all times. It's our nurses really that are at the bedside and working with our residents. So, if a patient gets discharged from the hospital, the first people that are going to see them when they get to the SNF is going to be our nursing staff. So you want to make sure that these inpatient handouts are so tight that it doesn't require a doctor to review everything to be able to kind of enact that plan as soon as the patient gets to the SNF. So on the SNF side, what can we do for our residents there? I think communicating both with the residents and their family members is really important, especially during change of status or like if you're about to refer the patient to the emergency department. Reviewing the medication is certainly important. The other strategies that work really well in skilled nursing facilities are also communication tools. And so similar to like our ED algorithm where we're like, okay, you're going to ask these questions when you do your wellness check, having that data compiled by a nurse when they're about to talk to a physician and having tools to make sure they've asked the right questions and gathered the right data makes those discussions just much more speedy and efficient. And then I think the other thing, when residents are going back to the inpatient side, going to the ED, a really good handoff with what you're worried about, what you're not worried about, why the patient's getting sent to the ED, especially if someone can't give subjective history, is really essential in transitioning back to the hospital too. All right, so I did want to give you one example from a long-term care setting. And this is one of these kind of what information do you need to gather to make a decision about antibiotic use or maybe not using antibiotics. So this comes from the AHRQ. There's a nice toolkit that goes through 3 syndromes, soft tissue infection, UTI, and pneumonia or lower respiratory tract infection. And it makes kind of this checklist that is just made for nurses, basically, nurses at the bedside. These are the things that would have an indication for initiating antibiotics. And then these are some of those key notes that, folks that are taking care of residents in long-term care should know about soft tissue infection, for example. And then also provides an alternative if those criteria aren't met. So other than an antibiotic. So instead of just saying like, oh, he's acting funny, he's going to get a urine culture, maybe we do something else like monitor the patient more closely, try to talk to them, gather more information before we make that decision. And this is an example from a paper that is a fairly older, but it really introduced this idea of what's called active monitoring protocol. So instead of saying, oh, I need to do something for Mrs. Jones, there's something going on with her, I don't know what it is, it's poorly defined. Instead of just saying like, okay, let's, culture her urine or start her on an antibiotic, let's continue to gather information and actively monitor this patient to get that information so that we can actually make a more sound clinical decision. So this is the example of their order set. It's an active process. More often you taking vitals, recording their fluid intake, and notifying if they've got their oral hydration has dropped off. And sometimes when you're more closely monitoring your resident in long-term care, you might find that it's not really a clinical problem that is the issue. It's more of an emotional or a social stressor that the patient is going through. So I think, this just means that they have more contact with the staff to gather that information, which I think is a really cool strategy and can avoid just the reflex antibiotic prescribing. All right, so this is the end of my talk. I'm gonna take a break and allow folks to ask questions. I think, the main things that I just want you to take away is that this is an area of opportunity and for improvement is for making decisions about antibiotics. There's lots of strategies that could be employed. So as you reflect on your own practice and where you are, what can you do to contribute to this, or who should you talk to try to improve that process? Because I really do think that it takes a multidisciplinary team to do this really well. And, it may take some structural changes. So templates, discharge templates, data feedback, and things like that. And then I think the other thing to take away is just it's everybody's problem. Don't be pointing to somebody else as that theirs problem. There are things you can do and they can do. So it's important to come together to work on this. All right, I'm going to stop sharing and see how we are doing.
Yeah, thanks, Dr. Mary. Are there questions for Dr. Maury? This while we are going. I would ask Dr. Spellman or Ms. Borland to bring your slides up while we have any questions. Dr. Pradhan, you got your hand up, I think?
Yes. Dr. Maury,
Go
wonderful lecture. Thank you very much. I'm internist, I'm outpatient, start practicing inpatient long time ago. One of the problem I find is when the discharge summary comes from the hospital, we live in the EHR world and we get 30-page discharge summary. I'm looking for one statement, pneumonia treated for 5 days, transition to PO antibiotic, treat for 5 days, reassess. That's missing. To find that information, you have to dig down all the data. So I guess one process would be improving that communication.
Right.
Would be worthwhile.
I definitely think that a structured discharge summary, instead of it just being a block of prose, there needs to be sections at the top with the main diagnosis, the major medication changes, and the things that need to be followed up, right, for our outpatient providers. So I don't know at Danville if y'all have that type of structure, but that is definitely, I think, tables help to kind of highlight those 3 pieces of information, but there are definitely structural template type changes that could help with providing more succinct communication.
Well, we have a number of people on the call that actually affect those things, so I think they've heard your message, Dr. Pradhan.
Great. Now, my second point is in the outpatient world, 3 things. We are living in the viral season, cold flu and COVID and RSV also going around. So 3 things people complaining about: sinus infection, UTI, and soft tissue infection. I know that's a big topic to talk about. Only thing I want to ask the question about sinus infection, and many times so hard to convince the patient antibiotic doesn't treat the viral infection. And if you give them short-term course, they will complain. What is your approach for the outpatient treatment of sinus congestion? How do you approach? How do you reach out?
Yeah, I think that was the last talk I gave a year ago, right, Michael?
Yep. Yes. Yes.
So there's actually really great training for, and it's like communications training actually that you can do. And I'd be happy to forward that back, but there's kind of like four main components. One is reflecting on the objective data that you're seeing, both from what they've told you subjectively, but also like through your exam, and giving a very clear diagnosis based on those data that you've just collected. Two, providing a two-part response. So, so this problem is not going to be treated with antibiotics, but this is what we are going to do to make you feel better. Because I think, one of the reasons patients really push is because they think, nope, they're not getting anything. And I think we can provide a lot of reassurance to be like, these are the things we're going to do to make you feel better. And maybe that is nasal saline and decongestions and things like that aren't antibiotics. But I think the most important thing is patients want to hear that you're doing something to help them and they want to feel validated. And then I think the fourth component of that communication training is contingency planning. So a patient that is feeling nervous that they're not going to get better, they know what to do if that happens, right? So providing some way for them to follow up, to get a phone call from your staff in 2 days to check on them, to know the red flag symptoms to call back for or come back for, making that to be like part of their plan. You can actually like give them homework and be like, this is what you're going to do. You're going to take your temperature. You're going to do this 3 times a day. And if you can kind of outline that plan, I think it provides a lot more reassurance. So that's the high level communications training for upper respiratory infection. But maybe we should do that one again, Michael, or I could just come for the primary care folks and do that.
That'll be great. That'll be
Dr.
great.
Mooring, there's also another question in the chat. I didn't know if you wanted to just look at it since you can see it now. Or
if you guys need to move over. Yeah. Okay. I can answer it in the chat if you guys need to introduce
the
next
I just didn't know if you wanted to read it. You can definitely answer it right now.
All right. So it says, in my current role as a physician advisor, which I'm not sure exactly what that means, I've recently been reviewing an increased number of patient charts with failed outpatient antibiotic therapy after the diagnosis. Patients are almost always admitted and placed on IV antibiotics, even with few symptoms. Your thoughts on this management, please? Yeah, I think it's hard for me to assess that clinical situation based on the description. There are several reasons why antibiotics treatment might fail. The one is maybe the diagnosis isn't correct, is the one. And then I think, drug resistance would be also a concern of mine. And then, those are probably the two main ones. Or if the patient's not able to tolerate the treatment that they were prescribed, that could be another reason. So hard for me to answer that one unless I do a specific case review for you guys.
Okay, Dr. Marion, thanks a bunch. We do need to move on to the next talker. Really good job. The second talk today, one on reportable diseases in the Commonwealth of Virginia, is how we started this program. And I'll be very transparent. This is something I was never educated formally on in my days in full-time practice at the urologic clinic. When we had something that needed to be reported, our nursing staff, which was excellent, would say, we'll take care of this. So, it was not something I had to personally do. So the more we thought about this request, it seemed like a really good topic. And we have 2 experts tonight to talk with you about the process and what is reportable in our Commonwealth. And the first talker, or they're going to do this together, but the first I want to introduce to you is Paige Boardwine. She is the Southwest Regional Department of Health's epidemiologist. And her background is she did her undergraduate degree at East Tennessee State University, one of my favorite schools. So many friends I've had have gone there, where she was selected for the Phi Kappa Phi Honor Society. Then she completed her Master of Public Health at Virginia Tech. She's going to be helped along with the talk by Dr. Scott Spillman. Dr. Spillman is our local district health director for Pennsylvania County, Danville, and Southside Health Districts. Dr. Spillman's background began his undergraduate educational career at Millsaps College in Jackson, Mississippi, in chemistry, followed by the University of Mississippi Medical School, or Ole Miss, for his MD degree. His internships were served at Presbyterian St. Luke's in Denver, Colorado, which was followed by a Master of Science in Occupational Medicine, again at Colorado Health Science Center, and a Master's in Public Health at the Medical College of Wisconsin. He was 10 years full-time faculty at Wake Forest University School of Medicine, where he had numerous major leadership roles in that school's teaching and educational processes. He's board certified in preventive medicine. He's a fellow of the American College of Occupational Medicine. And I think even more, or very uniquely, he is a recipient of the Boy Scouts of America Silver Beaver Award. That is the highest award to volunteer leadership. He has dedicated enormous numbers of hours and efforts to help the Boy Scout movement wherever he was at the time in his educational career. And to that, we thank him and thank him for his help with the youth. So all that being said, we're delighted to have you do the presentation and go ahead and get going. Thanks so much.
Thank you, Dr. Moore. That's more accolades than I deserve. And I want to thank Dr. Maring for, you were such a hard act to follow. And I'm glad Paige is on, because I'm got an adult helping me with this. So, it's what I want to talk about is you heard a lot about the research, the terrific research that goes on into how we each treat our patients individually. And I'm still a recovering country doctor from my days in Colorado when I was out in the rural parts practicing before I got into occupational medicine. And pardon me. And that is what you're living daily in your roles. And I transitioned into public health, both occupational medicine, preventive, and public health. And I see what you're doing and what we're doing is two sides of the same healthcare coin. And I guess that little sliver in between is research and government. And but we're all complementary here and working toward the same end. So we're going to talk about some things that the government, through using the research that's been created, has asked us, or the General Assembly has put in as requirements for reporting, and there are reasons for it, and that's to keep the public safe. The physicians deal with, typically providers deal with one-on-one, and we deal with one-on-many, many at a time, and we deal with what's going to keep the community safe at large. And this is where we focus in concert with what you're doing. And so it's a real partnership. So Paige, next one, please. Okay, we don't have any disclosures next. And of course, what we're talking about is a real barn burner here. So after this, you're going to be able to locate the Virginia disease reportable list, complete a confidential morbidity report using the online portal, describe your own, excuse me, responsibilities for disease reporting, and find contact information for the local health department. We're not hard to find. Go ahead. So what's a reportable disease? And there's a whole list of them. But first of all, why report? The why is always important, right? The incidence, prevalence, and severity of these diseases have impacts on our communities, both individually, the healthcare, and then ultimately, if it's bad enough, on the economy. Think about COVID that we went through and how that devastated a lot of our economy, as well as the education for our children for so long. This is why we want to be able to get things out the door, get our partnership going as quickly as possible. So first of all, it's the right thing to do. It furthers the partnership between community and public health, including the health department. It enhances the validity and accuracy of the information so that when we say, what have we got? The better information we get from you and the more timely, the better we can advise the public, including providers and the General Assembly, those politicians in that little sliver between on the middle of that coin, so that they can give us improve our resources available for facilities, clinicians, and the patients. And then, of course, it's required by law. That is, of course, the General Assembly statutes, and we have to talk about those. But the real thing is we want to do it because it's the right thing to do. Next, please. Now, here's one of those OHEC slides. Not too bad. The voters elect the General Assembly and the governor, and the GA passes codes that mandate to the Board of Health and the State Health Commissioner, which are both appointees of the governor. So the term is that they serve at the pleasure of the governor. And their promulgation then for regulations for disease reporting and control. Next. And here's a real OHEC slide. Now, I know some people are perhaps on from other states, perhaps North Carolina, but these diseases are the same across all states. These diseases are what they are. There may be slight by state differences in reporting. This is for Virginia. So some of them have immediate reporting, some of them have 3-day reporting, but they still have to be reported. You report all conditions, suspected or confirmed, and things like laboratory and certainty by standards of testing and care determine those, and our epidemiology team throughout the Commonwealth, locally and by state, can help with those things. Reports are confidential, and nobody who's ever reported these has been successfully sued that we're aware of, and they're protected from liability by the Code of Virginia. Next. Here are the things that are reportable immediately. And we'll just go through the big list. Bioterrorism. What is that? Stuff that can hurt you that people weaponize. Diseases that require prompt post-exposure prophylaxis. Diseases that are highly contagious, novel pathogens, and any outbreak, even if it's not on the list. So what would be some of the bioterrorism? Anthrax. It also requires prompt diagnosis and treatment. Meningococcal diseases. Other outbreaks, influenza A, hepatitis A, other things. There's a whole list. Some of you say, well, why these act slowly? Why are they that important? Sometimes they're silent, but they can affect so many people. Think of tuberculosis. And we handle and work with these all the time, and appreciate those of you who work with us. Next. Report it immediately. Call the local health department. There are also ways to report online. The sooner we know about it, the sooner we can help you get started. One of those might be to help you with even the diagnosis by some of the criteria that we use. We're not going to tell you how to practice. We just tell you what's in the standards that we know, and mainly it has to do with diagnoses. What's the best thing to send to the lab? Report it as soon as it's suspected. Don't wait for lab confirmation. If we say no, we don't think that's going to be an issue, and the lab comes back different, that might happen. But basically, we tend to take a pretty aggressive stance toward it. Think about things like rabies. Think about things like pertussis or plague, things like that. Go ahead. What do you report within 3 days? Well, they're not quite as bad, but they are pretty important. Enteric diseases, hepatitis B and C, healthcare-acquired infections, multi-drug resistant organisms such as TB, sexually transmitted diseases, toxic substances, vector-borne, zoonotics, and look through the list at your leisure. Think about mumps in a college setting. Think about hepatitis B or hepatitis C in certain other populations that are not necessarily the populations that have great insurance, things like that. There are a number of these here, and take your time and read through that, and you can look at those online. Go ahead, Paige. So who are the required reporters? Well, there's a whole lot of people. First and foremost, it's the providers, the physicians, NPs and PAs, or their immediate designees are required. Laboratory directors. So if you send something to a lab and they identify it, they should be notifying you right away, but they should also be notifying the health department, or fill out those forms that go up to the central office and report up to VDH Central. Inpatient, outpatient, emergency care, people that are in charge of medical care facilities, local health directors. If we find something, we're gonna or notified of something, we're going to report it immediately. And there are systems and all kinds of software for these things to go in for evaluation and monitoring. Also, people in charge of residential or day programs, other services, or facilities licensed or operated by state agency, such as the skilled nursing facilities that you heard about, schools, child care centers, or summer camps. Think about church camps, think about scouting, think about other youth, maybe even music or sports summer camps, and all those. And by the way, my mother was a flautist as well, Dr. Mary. Okay. All right, next. I think you take over now, Paige. You're on mute.
Thank you. One of the things that is confusing, sometimes even to public health folks, is what qualifies as an outbreak. Well, the definition of an outbreak is more cases in excess of what we normally expect. And understanding what the baseline is one of the things that our local epidemiologists do. And I feel like I have to point out um, the Sovah folks are very fortunate in that you have one of the best health directors in the state in Pitt, Dan, and Southside, and your epidemiology team for both West Piedmont, Pitt, Dan, and Southside are stellar. So you have some of the best that cover your area to help deal with these things. So some examples of an outbreak, norovirus, an outbreak in an assisted living facility. We have many of those as of 5 o'clock today. And norovirus as an illness is not on that reportable disease list. However, if there is a cluster noted, for example, if you're in an office practice and 3 of your patients from the same elementary school with in the same grade come into your office, that would be a time to give us a heads up, and we can do some follow up with the school or whatever facility it is. A mumps outbreak on a college campus. Um, the immunization for mumps tends to wane over time, and behavior on college campuses sort of predispose some of those folks to acquiring communicable diseases. So we see this kind of thing often, and we provide guidance to the campuses on how to safely manage their faculty, staff, and student body. Hand, foot, and mouth disease outbreak in a child care center. Again, we have several of these outbreaks currently. And just to note, if there are those of you that are not practicing in the state of Virginia, but you are treating a patient who resides in Virginia, you still have to follow Virginia's reporting laws. Um, so those things still have to be reported to the state of Virginia. So just a reminder, if there is an outbreak of an illness that is not specifically listed on the reportable disease list, that outbreak is still reportable. And who uses the term outbreak? Who makes the decision that something is an outbreak? Well, that lies with public health and our investigation. And one of the things that we want to collaborate with clinicians on is getting information back to you on how this outbreak is going, or guidance that it might be helpful to provide for your patient. And again, we don't want to get between the relationship of you and your patient, not at all. We want to enhance that. Okay, what should the reports include? Well, the disease or condition which is diagnosed or suspected, the method of diagnosis, if available, and it's important if there are extra lab tests that might help with that diagnosis. And the most common example I can think of, any of the hepatitis illnesses, hepatitis A, hepatitis B, hepatitis C. We would like to see the liver enzymes. And is it okay to report that to us? Yes, absolutely. And we're going to get into a little more detail about that. We also want the patient demographic information: patient name, date of birth, age, sex, race, ethnicity, pregnancy status, address, telephone number. Pregnancy status is important to us. If we are looking at pertussis, then we want to work with that patient's OB and make sure that they're aware that their patient is, either being prophylactically treated for an exposure to pertussis or has been diagnosed with pertussis. And then we want the healthcare provider information, and that's important if we run into issues and we have additional questions, or there are times we might suggest some additional testing. And often, a lot of that testing we can send to our state public health lab, and if you're ordering it, ordering your list of tests, that's not something you order in your system. And I don't remember if you guys are Epic as a electronic medical record, but if we are testing through the public health lab or if we forward to the CDC, then there's no charge for that testing. And then again, the name, address, and telephone number of the provider. So just a quick review of the reporting highlights. And if you get really bored or if you're having trouble sleeping, this is riveting reading at night. But here are the things that are important to you to know as a clinician. The Board of Health is mandated to create the list of reportable diseases. We have a new illness that is coming on that list in July of this year, and that is alpha-gal syndrome. So we'll be working with folks on reporting that, and the Southwest is doing a pilot project currently to start looking at some of those cases and try to determine the best way to manage this to make it less onerous for both clinicians and public health along with the patients. The next portion of that code is physicians and, not or, it's and. Physicians and directors of laboratories must report diagnosed or reasonably suspected cases that are on that reportable disease list. And why do we need both? Well, we need both sets of information to combine it and try to do the best investigation so we can make the appropriate recommendations for the public. And it might be the public as a family, it might be the public as a 5th grade class in one of the schools or a long-term care facility. The health commissioner may disclose the patient's identity and disease to their employer if it is a threat to public health. And the most common times when we see this are food service workers with hepatitis A. And so that's something we have to work with really quickly, because if a food service worker does have hepatitis A, they can transmit that to many, many, many people. And that is not an uncommon thing. We had a food service worker that didn't consider herself a food service worker because she was a dishwasher working during one of the largest festivals that we have in Southwest. And so we were a few days behind the curve because we didn't know she worked in a restaurant. And during that time, she touched every single clean piece of silverware, clean dish, and there were many people over 7 states that were exposed, and a number of them did come down with hepatitis A. So that's a time sensitive thing. And at that point in time, we would disclose that information to the employer, but the commissioner, the state commissioner for Virginia Department of Health approves that. Physicians and directors of laboratories can voluntarily report additional information for surveillance or epidemiological studies. So let's say that when we started seeing mpox, that wasn't on the reportable disease list initially, but we were asking physicians and directors of laboratories to report that until we could get that added to the reportable disease list. Additional highlights, and this applies to you, anyone reporting in compliance with this particular chapter of the Code of Virginia is immune from civil liability or criminal penalty. The names of the persons reported and those reporting will not be disclosed. Even if a patient asks for their records, we redact all clinician names and facilities from that record. The commissioner or their designee can examine and review any medical records related to investigations, research, or studies of public health importance. So at that point, the practitioner shall not be liable for permitting such examination and review. It is not uncommon for us to reach out to clinicians, hospitals, and ask for additional information if we're trying to work through an investigation. We do preserve the anonymity of each patient and practitioner. So once you report to us, we have to follow the same privacy guidelines that you do. And we have to maintain the anonymity of the patient. We also maintain your anonymity. And again, that identity may be divulged at the sole discretion of the commissioner. And a good example for that, and I've been around in public health a while, but a number of years ago, there was the contaminated compounding steroid that we did have to divulge to the public the facilities that received that steroid so that we could identify patients that reported there. But if we're going to divulge something about a practice, you're going to know about it first. We're going to be the good neighbor and talk to you about that. State law requires those list of diseases and outbreaks. Outbreak is one of the reportables on that reportable disease list. So Dr. Spillman talked about the immediate reporting of some illnesses and others within a 3-day window. And that 3-day window, we ease up a little bit on the suspected there, so we can wait till diagnosis on those. The immediately reportables, if that's in your differential, we want to know about it because there are actions that we can take. Then, as if we didn't have enough riveting reading, there is the Virginia Administrative Code, and that covers the outbreak section. So all outbreaks, foodborne, healthcare associated, occupational, toxic substance related, waterborne, or any other outbreak is listed as a requirement in the Virginia Administrative Code. And in this presentation, the links, you should be able to click on them and it will take you to that if that's something you want to read through. And in one of the paragraphs, again, it defines a little more about outbreaks. So the occurrence of outbreaks or clusters that may represent a group expression of an illness that we might be concerned about shall, not should, but shall be reported to the local health department immediately by the most rapid means available. And we're all on call 24/7. And later in the presentation, we put the cell phone numbers of the epidemiologists that cover the Sovah system. So what can happen if you don't report? Well, this is in the Code of Virginia. Refusing or neglecting to comply with reporting requirements is subject to the imposition of a criminal, which is a class 1 misdemeanor offense, and or civil penalty, and that is up to $25,000 per day per violation. So if in your clinic you saw 10 patients and all 10 of them had a different reportable disease, it starts out with $25,000 per disease. So, and again, that's in the Code of Virginia and not the Virginia Administrative Code. So some of the reporting methods, there is the EPI-1 form, the confidential morbidity report that you can print off in paper, and I have a PDF link here, or there is an online portal, and you can report online. And I see Dr. Spillman, do you want to go ahead and address that question?
Can you see that, Dr. Spillman, or do you need me to read it?
I can see
That's
it.
from
I'm
Dr. McIntosh.
okay. Thank you for that question, Dr. McIntosh. How concerned about tuberculosis? Wow, it's a little bit hard because it's, you know, people, there's always a risk. People travel a lot more than they used to, right? And so a lot of east west and north south travel, um, and I think that if you have patients that go to this basic area or come in contact with someone who has been in that area or been around someone that has had that, then just start doing a symptom check on them. And you can always, I think, just like the last, the prior presentation, you don't necessarily automatically put them on antibiotics. You want to assess them, check things out. Uh, don't want to get too excessive with the chest X-rays. Once in a while, you might need one of those, but watch them and again isolate and have them rest. You can do tuberculin skin tests. You can do the IGRAs and those types of things. They're not going to show up immediately, so you want to watch your your people. If it's somebody that you suspect is having been exposed for quite some time, at least I think it's like 11 weeks between point of exposure. A TB skin test or an IGR should, and maybe even a chest X-ray should help you with this. How concerned? I think it just depends on the particular individual's, um, uh, you know, exposures or potential exposures to people in that area or traveling to that area. And I don't have any additional information about that at the moment. I think it's just something we're going to be watching for now and just see where this goes. I do expect that this could be expanded. Um, if you think about the upcoming Super Bowl and people traveling and think and national events have an option or a possibility of spreading more quickly because a lot of people come together. So just be on the lookout, and I think an awareness is the big thing. Hope that helps. The CDC will certainly keep up with this, as will VDH. Thank you.
Thanks for that awesome answer, Dr. Spillman. And just an additional point there, one of the things that we do, we get airline manifests at times if someone flew into Virginia and listed Danville as their final destination, and they were sitting beside someone on a plane or sitting in the appropriate distance for an exposure, then we're going to follow up with that person and potentially refer them to their clinician, and we try to reach out to the clinician ahead of time.
Yeah,
um oh
I'm sorry. Another thing is
yeah,
if they're hospitalized for this diagnosis or in some other perhaps another health department in another state or area, and they know the person is coming back to your area, they should be notifying us as well. And then we would be helping. We would partner with you about monitoring and doing the right things for that type of disease, whatever that is. Say TB, for instance.
absolutely. um we can do a computer generated printout. So there are facilities that they send a list of reportable diseases daily with all the information to the local epidemiologist. There are surveillance forms that keep us on track. There's one of those for each illness, and that gives us the list of questions that are important to identify. We can kind of go off script from that, but that keeps us on track in collecting the same information for each patient. You can do electronic submission securely. So we have a number of our larger hospital systems that they can submit electronically all of their reportable diseases each day, and it submits the lab, it submits all of the information that we would need as public health. And I don't think Sovah is enrolled in that, but if that is of interest, please reach out to myself, Dr. Spillman, the epidemiologists on that their contact information is in a later slide, and we'll be glad to help you start the discussions and get you enrolled so it makes reporting easier. And then a phone call to the local health department. We love talking to our providers. We really do. Um, and we want to know, what's going on with your patient if you have a concern. So, those are all ways that you can use for reporting. This is the online confidential morbidity report. It's a little bit easier for clinician offices or urgent cares to utilize this. The hospital infection preventionist report for patients inside the hospital. So they cover the physicians for that, but in the offices, someone has to be designated to do that. And that's just a photo of the portal. It's a REDCap survey, and it enters the work queue for the appropriate local health department. There's also a printable form if you still like to fax things, and that's perfectly acceptable. Here's a little bit about the automated case information. So this is a secure transfer that is HIPAA compliant, and our informatics team works with the hospital informatics team and help get that set up. And again, if that is something that is of interest to the Sovah group, we'll be glad to do that. Okay, go really quickly through the VDH overview, and here's an org chart that kind of lists how VDH is laid out. Dr. Karen Shelton is our health commissioner, and Dr. Spillman and I are kind of on two different sides of the org chart, but we still work together, sometimes daily. Okay, what do we do with that data that you send us, that information? We confirm the diagnosis and review any relevant lab results, and we may call to ask for some additional lab results. One of the things that comes up pretty often is hepatitis A. So any of the serology for hepatitis A, if you do a hepatitis A total antibody, then that flags to the health department. But our guidance is if we have an IgM positive for hepatitis A, then that's actionable. And so we may call to ask some additional information. We may request that additional testing be done, or we want to verify that this person does not have symptoms. So those are ways that we try to collaborate with you. We review medical records. We want to look through the medical records to see if there is a history of certain things. If, when did the symptoms start? If we're going to recommend post-exposure prophylaxis, if we have to look at contacts. So we want to look at all of those things, and then we interview the patient. Oftentimes, we want to collect the information about their illness, their contacts, verify that they're taking whatever treatment their clinician provided them. And then we utilize a case definition that the CDC has created to count cases with the same information being used nationwide. So let's look at, I'll go over this slide and then I'll talk about the case definition. How do we intervene? We might recommend post-exposure prophylaxis. And one of the things that we do is refer that patient back to their primary care provider. We don't want to get between that relationship of a patient and their clinician. If we recommend post-exposure prophylaxis, we do have to consider antibiotic stewardship, and we want to make sure that we are not inappropriately recommending antibiotic therapy, pertussis is probably one of the biggest things we often recommend prophylaxis, or occasionally the STIs, sexually transmitted illnesses. But if there is a group that has been exposed, and there's a different definition for what an exposure is for every illness. So if we find that, let's say it is a kindergarten class, and in that instance, kids that age are up in everybody else's business. And so they are going to be exposed if there's a child with pertussis in the class. Let's say we recommend post-exposure prophylaxis for the entire classroom. Usually we put a letter on local health department letterhead and send it to the appropriate physicians. So if there's one or two pediatric practices, then we'll send it to say Miss Smith's kindergarten class at this school has been identified as being exposed to pertussis. And it doesn't mean that if there are other age kids in the family, we don't recommend it for all of them. We recommend it for just the folks that are exposed. And if that person has to come in for a visit, that is up to you. That is between you and them. Um, if you feel comfortable calling in a prescription for post-exposure, which is a Z-Pak, and thankfully pertussis, the same treatment, is also post-exposure, we want to let you know about that, but we also are not going to recommend it for anybody that doesn't need it. We want to exclude the case from working in or attending high-risk settings. We want to look at our food service folks. We want to look at healthcare folks. We look at childcare. We educate the patient and the contacts. We might recommend isolation and quarantine as necessary. And then we might suggest initial additional testing of the initial specimens or isolates. We have the capability to do whole genome sequencing. We might want to test the contacts, or we just recently had a case of Salmonella typhi. We have to have clearance samples to end their exclusion. So this particular person was an ICU nurse, and we had to make sure that she had 2 negative stool samples 24 hours apart before she can go back to work. So, we want to protect those facilities. So our case definition, there is a case definition for every illness on that reportable disease list and then some. And that tells us how to classify cases. Is this case confirmed? And does it meet the appropriate criteria? So the example is pertussis. We look at clinical and laboratory criteria that allows public health to call this a case of pertussis. And that's important in us looking at funding, us identifying illness in the community and things like that. So the clinical criteria, cough illness greater than or equal to 2 weeks with one of the following: paroxysms of coughing, inspiratory whoop, or post-tussive vomiting, or apnea. So that's the clinical criteria, and then we look at the lab criteria. So to confirm a case of pertussis, it's isolation of Bordetella pertussis from a specimen, that means a culture, or a positive PCR for pertussis. And that's the only 2 things that for us to count a case are appropriate. Does that mean if you clinically diagnose a case of pertussis and don't test it, that you shouldn't treat it? No, it doesn't. We still want you to tell us if you're not going to test for it. That's where we want to know if you suspect it. And, we can partially count it, but we want to be able to look at the burden of illness in our areas. And I'm going to turn it back over to Dr. Spillman.
Thank you. Thank you. Pardon me. One thing about the contact tracing, think back to COVID. We have a whole team that we contracted, and virtually every other health department in the state did, and quite frankly, across the country, to the incident reporting, then there's the contact tracing. All the people that were exposed substantially, or we would find out who was substantially to that individual or small group, and then to try to get to the most likely people who would be affected. And on behalf of all the epidemiologists and all the health departments that do this, we run into problems with people not wanting to sort of rat out or tell on their neighbors or their friends. And of course, now with a different administration, people are concerned about if they're here without documentation properly, that might be an avenue for removing them from the country. Again, we do our very best to keep everything as to comply with HIPAA and keep everything private. So just it's very important if you think about certain funded places such as shelters. Plus if you think about healthcare institutions, if you think about places like churches, schools, any other kinds of, we talked about camps, a lot of other places, so many ways that people got sick with that. And sometimes it was just one class or one floor in a building at a time in a school, or one building in a school, things like that. So all that just, so please encourage your patients, if we do get called, to just give us the information as best they can. And again, we're not trying to be intrusive. We just want to try to get the best information possible to help everybody. Pardon me. So responsibilities, know how to contact your local health department on and off hours. And again, the slide with our EPIs in both districts. Report diseases is mandated. Call the local EPI for questions and collect the specimens as we just talked about. Next slide. Okay, so for clinicians, what's next? So advise your patients to isolate. So if they're ill, separate them from the rest of the world if possible, and isolate. Wait for the labs. Sometimes the labs don't bear it out. You're just dealing with whatever clinically is there and whatever you think is necessary at that point. Educate the patients on their diagnosis, basic control measures wherever they're isolating to help minimize their own time in terms of being ill, as well as spread within that locale. Prescribe what other medications that are supposed to be there, and tell the patients to expect a phone call from us. And again, we do it respectfully, and we just are trying to, we're not doing anything accusatory. The people haven't done anything wrong. We just need information. So it is pretty much very, very bland in that sense to us. We just want the information. And then be alert for any public health advisories. Next. Pardon me. Here's just a quick colorimetric version of all our of the health districts. The pink that says Pennsylvania Danville, that's one of my districts. To the east is Southside, Halifax, Mecklenburg, and Brunswick. To the west, of course, you have Martinsville, which is also a Sovah facility, and then you've got the three Patrick Henry and Franklin counties. So that makes it West Piedmont Health District. Those are the two probably you'll be the most likely to become involved in, perhaps Halifax. And then, as you can see, there are others. And just as a quick thing, Paige covers, if you look, Pennsylvania, then Central Virginia, then Allegheny and Roanoke. Everything west of there is what she covers as the regional epi. So that's a good quarter of the state, if not more. Next. And here are the contacts. Chris Andrews is our district epi for Pitt-Dan. Heather is our deputy epidemiologist, and McKenna is our epi for Southside. And then in West Piedmont is Ms. Sharon Ortiz Garcia, and then Corrine Rogers. And all of these people are very professional and will do their best to answer your questions and get what's necessary to help you. You're always welcome to call me. If you call me and you haven't called them, I'm going to primarily put you back over to them, because they have the software and the other things that they can get into and mine some of that data for you. Next. So trustworthy sources: bdh.virginia.gov /epidemiology, BDH, CDC, pink and yellow books, and then other standard references. And then there are others as well. Next. Case study and Paige, I think that's yours, depending on how much time we've got. I see Dr. Moore. That's kind of like the shepherd's crook coming back out to pull us off here. So, Dr. Moore, do we have time to do that or not?
Well, we're 4 to 9. We're really running short on time. We probably just need to wrap up at this point if we can.
Okay, Paige, go for it. Just kind of the key things there. Hearing.
It would help if I unmuted. I'll let you guys look at the information on the case study. The most important thing on this slide is the testing. The two things that for us to count pertussis, it's going to be culture or PCR. We can't do a lot with serology. I think there's an antigen test out, so we can't do anything with those. All right.
They might help, but we can't use them as confirmed.
Right, exactly. And let's move on. We do recommend post-exposure prophylaxis for pertussis contacts, regardless of vaccine status. And then we do have a number of places that you can connect with us. There are clinician letters, there's a monthly newsletter, so we encourage you to take a look at that. And with that, we'll take any questions.
Are there
believe
questions?
It or not, we cut that down to about 1/3 of what the information really was.
Okay, we have questions from anyone?
We do. Dr. Dupre has a call. I'll read it to you. She does dermatology. Please expand on the upcoming 7/2025 requirement to report alpha-gal tests by the labs, followed by the clinical documents from the physicians. In my office, we order this test each day on multiple patients. In addition, we monitor the patients with serial serology. How can this reporting requirement be streamlined? What form will be used?
So that is something that Southwest gets to determine. And I would be happy to take any comments on the best way to report that to VDH. We will start to work with some of these alpha-gal cases, and we are looking at a way to deal with the serial serology, and we're working on developing an online portal for you to just put that information in. So we should get the lab once it's reported. We just need the patient information along with that. So we're trying to make it as simplified as possible, but if you have suggestions on how this might work best for you, please reach out to me. And my email is on one of the earlier slides. And I see the rationale for adding alpha-gal to the reportable list. There are some severe cases, but it's one of those things that we are starting to see more of. And I think it's going to be a changing landscape, and for us to provide guidance as appropriate, and we are talking to North Carolina. I think they're waiting to kind of see what Virginia does, and we are talking about, how to approach this, because this is going to be a more difficult issue to report just because of the serial testing. So we're working through that, but please feel free to reach out to me.
The other thing is that I think in trend analysis that showed that it was increasing without leveling off. And I have a number of my own staff that are alpha-gal positive, and it really surprised me how many people. And when I found out, I think these are optional for encouraged to report now, but required later. And I think it was just primarily to get a handle on it and to see just what we need to do. And it might drop off later, but I think they're just trying to see just how much a problem it really is before we do any other types of mandates. Thank you.
Any other questions for our speakers?
I don't know if you can answer or share any information. Do y'all have any updates on H5N1 for Virginia?
Actually, I can go ahead, Dr. Spillman, and
Go
you may
ahead, you
have
go for it.
additional. We do not have any human cases at this point. We do have 2 animals who have tested positive, and we have done a lot of preparatory work in Virginia. We have reached out to all of our dairy farms, all of our commercial farms, our commercial poultry groups. We're looking at the flight path for birds and things like that. We've provided PPE and education to all of those farms and continue to interact with them in the event that there are cases that come up.
There was a something that we signed up for, the CDC, um, and I think the ISDA held a webinar the other day and had cases from multiple parts of the state, including California. And I'm sure you're aware of all that. And we have a summit, what we call an emergency preparedness and epidemiology summit in March, and that's one of the topics that we'll be addressing at that time. I wish we had more information for you. I apologize that we don't. We could probably find some good data for you, but I suspect you have about as much as we do right now, maybe more.
Yeah, I was looking for the inside scoop. I really, really just want to say thank you for working in public health. I think that is an essential, critical job. And I feel very grateful that y'all are able to talk to us tonight.
You're very kind. Thank you. It's our pleasure. We do this. I went back from a private job into an academic job with what was then used to be called Wake Forest Baptist, and into this willingly, and I'm so glad I did. It really is very meaningful to me. And you keep doing what you're doing.
Well, we're going to keep doing what we do and have another program next Thursday night, which we hope everybody will come back and be on the call. Any last questions for any of our 3 excellent speakers this evening? Well, we are running a little over our usual time, so not to keep you any longer, we do hope you'll rejoin us next week and hear the talks on update on atrial fibrillation management and anticoagulation for DVT and pulmonary emboli, and for patients who are coming in for elective things and managing their anticoagulation around whatever their intercurrent illness might be. That being said, thanks to Mary Kent for managing the technical side of this evening. Thanks to each of our speakers. As I remind our residents each time I gather with them, please be careful out there. And we look forward to seeing you back next week. Have a great evening. Good night. Bye-bye.